Thank you, Susan. Liz Stuart is going to be speaking with us today. Liz is a Bloomberg Professor of American Health in the Department of Mental Health at Johns Hopkins in the School of Public Health. I have cheat sheets here because there's a lot of information. She has joint appointments in the Department of Biostatistics, the Department of Health Policy and Management. She received her PhD in statistics from Harvard in 2004, and she is a fellow of the American Statistical Association. She has extensive experience in methods for estimating causal effects and dealing with the complications of missing data in experimental and non-experimental studies, especially as applied to mental health, public policy, and education. Her primary research interests include designs for estimating causal effects in non-experimental settings, such as propensity scores, which we'll hear about today, and methods to assess and enhance the generalizability of randomized trials to target population. She has received research funding, as you might imagine, from a long list of funders, including the National Science Foundation, the National Institutes of Health, the Institute of Education Sciences, and the WT Grant Foundation, among others. She has a long list of awards that she has already won. I first became aware of Liz when I was walking by my daughter's room one day, and she said, "Hey, you wanted to know about propensity scores. You couldn't learn anything more about it better than from this person." My daughter, like many other graduate students, is doing her work from her bedroom these days. So I came in and I had the privilege of being able to watch Liz talk about propensity scores, and lo and behold, I really understood and got it in ways that I hadn't before. So that was one of the reasons that I wanted to invite her to speak with us today. That and the fact that her husband is Canadian, so she has a little fondness for us as well. I am told that her causal inference in medicine and public health course is one of the most sought after courses in the School of Public Health, and there's always a long waiting list of people who can't wait to hear what she says. So without further ado, I will turn it over to Liz. If you have questions as we go along, I'll ask you to put them in the chat, or we'll stop from time to time and you may be able to ask a couple of questions, and then we'll have some time at the end as well. So welcome, Dr. Stuart.
Great, thank you so much. It's nice to be here. I see a couple of familiar names in the list, which is also nice. I think the last time I was at McGill was about 8 or 9 years ago. And I should say you have some great experts in causal inference and propensity scores in the epibiostat department. So you have some local expertise too. But I'm here to kind of give an overview of propensity score methods. I'm kind of assuming low level of knowledge. And as Susan said, I'm really happy to have questions throughout to make it sort of more fun for everyone, especially when you're not in the same room and I can't see faces and whatnot. It's going to be more fun to have it. Questions throughout. Sorry, I'm like, no, I can't actually open the chat, so that's all right. I'll just rely on Susan to jump in and tell me of any questions. Oh, there we go. Anyway, great. But yes, it's really nice to be here. And yeah, my husband grew up in Brockville and went to Queens. So it's always nice to be sort of back in Canada. So yeah, my goal is to, in, I don't know, 40 minutes or so, give you sort of an overview of propensity score methods. I imagine some of you actually probably have a lot of expertise, and this might be very introductory. I welcome sort of some of those more advanced questions and things. I'm gonna just sort of assume, but we'll kind of assume a low level of knowledge so to get everyone on the same page. Oops, there we go. Okay, so the kind of premise here, and the reason you all might be here to listen, is that there are some important causal questions that can only be answered using non-experimental studies. So this might be sort of exposures that we just wouldn't ever impose on someone, like the effects of childhood maltreatment on later mental health status. Or it might be because we're interested in sort of looking at the effects of commonly available treatments, such as medications or other therapies. The current COVID situation, I think, is a case in point where even we might want to be doing, say, randomized trials of convalescent plasma or other treatments, but there's so much use of those therapies kind of outside of randomized experiments that sort of we might need to be able to learn about their effects without the benefit of the randomization. So of course the problem is confounding, where the people who either select or receive one of the treatments who are exposed to some risk factor of interest are likely different from those who don't. And so it's hard to know if there's a difference in outcomes. It's hard to know whether that's due to the actual treatment or exposure of interest, or whether that's due to these other pre-existing differences between the groups. So propensity scores are one solution to this. I want to be clear, there are other non-experimental study designs. The causal inference course I teach covers propensity scores as well as other strategies like instrumental variables or regression discontinuity. But propensity scores are a good tool to have in your toolbox for non-experimental studies. I'll of course talk more about exactly kind of how they work, but I just want to highlight that one of the benefits of them, and I think one that's particularly useful in sort of high stakes kind of regulatory type situations, is like how a randomized trial has a separation of design and analysis. We do the randomization before we can see outcomes. Using propensity score methods can sort of provide that same separation. So this idea of setting up the design of our study before we kind of bring in the outcomes and actually compare outcomes. Fundamentally, the kind of one sentence on propensity scores is that the idea is that we're trying to basically replicate a randomized experiment kind of as much as possible by forming groups, sort of exposed and unexposed, who are as similar as possible on the observed covariates. There's going to be a catch there, note that I said observed covariates, not all covariates, so we'll come back to that. And I will say one part of my work is what we're talking about today with propensity scores. I am also interested in this question of how well can we generalize results to target populations. And there is a benefit of non-experimental studies where sometimes they can be conducted in, again, sort of more representative populations, maybe in a whole electronic medical record system for a health system, or some other kind of population data set. And so there's a way that you can sort of balance the sort of internal and external validity to some extent. So I'm going to use a motivating example throughout just to make things concrete. And this is going to be looking at the effects of psychosocial therapy after a suicide attempt. As you'll see as we go along, this is kind of a best case data scenario. So I'll clarify what I mean by that as we go along. But just to set the stage a little in terms of the content area, as you can imagine, looking at the effects of interventions on suicide risk is difficult. Suicide luckily is fairly rare, and so looking at interventions to prevent suicide requires very large samples and a very long-term follow-up. So this is hard to do in a randomized design of any sort of normal scale of the studies we might be able to afford. It has been done a few times, but it's unusual. So what we were doing in this study was basically taking advantage of a suicide prevention clinic sort of rollout that happened in Denmark starting in 1992, and take advantage of this amazing Danish Registry data basically to compare outcomes of people who got this psychosocial therapy after a suicide attempt, compare them to people who didn't. And again, what's really amazing about this registry data, which I'll say a little bit more about, is that it allows long-term follow-up, as well as it has incredibly extensive information on the individuals who had a suicide attempt. This was joint work with Annette Erlingson. The paper's getting a little old, but I think, again, it's a really nice example of kind of how this can look in a non-experimental study and the use of these large-scale data sets for this kind of project. Okay. So let's formalize a little bit what we are trying to do here. So the premise is that we are aiming to estimate a causal effect. We are interested in the effect of some well-defined intervention compared to some comparison condition. So I don't know if all of you are familiar with the idea of potential outcomes. But the idea is that for each person, there is some outcome that we would observe, say a repeat suicide attempt, if they receive the treatment of psychosocial therapy in our case. And then there's some outcome that would happen for that person if they don't get the psychosocial therapy, the comparison condition. And so the causal effect for person I is, say, the difference between these potential outcomes, their outcomes with the intervention and their outcomes without. What's called the fundamental problem of causal inference is that for each person, sort of at a particular point in time, they either get treatment or control, they're exposed or they're unexposed. And so we only observe one of these potential outcomes. So for each person at a particular point in time, we only see one of these two values. So we kind of can, essentially, this is where causal inference can be thought of as a missing data problem, where we're essentially trying to impute or model the unobserved potential outcomes. One sort of just side note is that this issue of the missing potential outcomes is, in my world, what distinguishes causal inference from associations. So an association might say, what is the rate of suicide among people who live in urban areas and compared to the rate of suicide among people in rural areas, like two different groups of people. Here, what we're interested in for a causal effect is a comparison of these potential outcomes, but for the same group of people. So for this particular population, what would their outcomes be with exposure compared to what their outcomes would be without? So again, sort of comparing potential outcomes for the same population versus an associational measure, which might be comparing outcomes among two different groups of people. It's a little just aside. So sort of at an intuitive kind of level, ideally to estimate, to sort of predict these missing potential outcomes and estimate causal effects, we would like to be able to compare treated and comparison, or exposed and unexposed people who are completely similar to one another on all baseline characteristics. If we do that, then we're able to say, okay, if we do see a difference in outcomes, it must be due to this treatment, because there were no other differences between these groups. So this is where randomized experiments are useful, because they give us this, what's called balance, this similarity in expectation, at least. So in a randomized experiment, we know by virtue of the randomization that the exposed and unexposed groups are only randomly different from one another on everything, up until they get the treatment or not. So what, again, propensity scores try to do is to say, well, we don't have randomization, but what we can try to do is find groups that are as similar as possible on at least the observed baseline characteristics. So we, again, sort of like we would have a table 1 in a randomized experiment that shows similarity of our treatment and control groups, we want to be able to show a table like that in a non-experimental study, showing the similarity of exposed and unexposed. So again, propensity score methods we can think of as their sort of goal is to make the groups look as similar as possible on the observed covariance. This is what Paul Rosenbaum calls dealing with the overt bias. And then we do have this concern that I'll come back to about unobserved differences. We can't equate the groups on things we don't observe. And so as a second step, we will do a sensitivity analysis that says, well, what if there is some hidden bias, some unobserved confounder that we're not able to sort of adjust for and equate the groups on? So mostly what we'll talk about is sort of this first step of how do we do this, dealing with the overt bias. I'll go like 1 or 2 more slides and then see if there's any questions. So the problem is that, in some ways, this idea of sort of forming similar groups goes back years and years and years to even like the fundamental ideas of like stratifying. We think, oh, well, I'm going to stratify by age because I know that there might be confounding by age. And if I stratify by age, that will remove some of that confounding. The problem is that once we have more than like 2 or 3 covariates, you basically can't stratify. That once you, again, sort of in normal size samples with more than a couple categorical covariates, you just can't find groups that are identical on each of the variables individually. So what propensity scores do is they are basically a particular type of dimension reduction that allows you to find these people that look similar using just the propensity score, and not having to deal with each covariate individually. So instead of saying, oh, I have an exposed person who's 62 with heart disease and lives alone, and I want to find a comparison person who is 62 with heart disease and lives alone, instead of having to do that sort of direct, exact matching, we will estimate a propensity score and say, I'm going to try to find people with similar propensity scores. And I'll define exactly what that is in a minute. So again, there's sort of two key features of randomized experiments that this process is trying to replicate. The first is this idea of forming groups that look only randomly different from one another, at least on the observed variables. And then the second, and again, this is sort of this regulatory piece, is that the outcome is not used when setting up the design of the study. So we will use our propensity scores and set up the design without using the outcome data. I think this can be incredibly useful, again, in sort of high stakes settings, because you can sort of say, look, I didn't know what results I was going to get. I did this design. These were the matches I got. This was the sample I got. And I had no idea what the outcomes were going to look like. And I sort of, for years, I had been saying, oh, I should like ditch academia and go, if I was an entrepreneur, I would like go set up a company that would like have an explicit firewall. And like, so pharmaceutical companies could hire me to do the propensity score stage, never see the outcome data, hand it back to them, and sort of have this firewall between the design and analysis. And FDA, for example, might then sort of trust that more because they would know, again, that there's this separation. It turns out someone else, actually, I'm not an entrepreneur, it wouldn't have been a good career stage for me. It turns out someone else has actually had that idea down in North Carolina. So it's sort of both gratifying and like, oh, I could have been living the high life now. But it's that sort of idea, again, where we can sort of try to minimize the potential for bias by not using outcomes in the design stage. Okay, I'm going to pause for a second, see if I don't see any questions in the chat, but just any.
Hi, Liz, it's Robert Platt. You said something just now. I was starting to type something that you said something that triggers a ton of confusion when people see these for the first time, but you said it clearly, and I just wanted to amplify why it should clear up confusion. There's confusion about whether you should use knowledge about the outcome in construction of the propensity score versus the outcome data in the propensity score. And what you just said is don't use the outcome data in the propensity score, but that doesn't mean that you shouldn't use knowledge about what predicts the outcome, because that's how you tell if something's a confounder or not.
Totally agree. Yes, that is a great distinction. Yep. And that will come up a little bit as we go along. Yep. Yeah, in fact, like the scientific knowledge about likely predictors of outcome or confounders are crucial. That scientific knowledge is crucial. So let me turn to like why use propensity scores. A lot of people have been trained like, oh, I can just put the covariates on the right-hand side of a regression model and that controls for those covariates, and isn't that accomplishing the same thing that propensity scores will? It's hard to really talk this through in 2 minutes, but I will try. And basically the reason propensity scores are preferable is because of extrapolation and sort of dangers in extrapolation. So traditional methods like just simple regression adjustment, basically if your treatment and control groups are quite different from one another, let's say they have very different age distributions, that means that your outcome under control is observed, say, in a young group, and your outcome under treatment is observed in sort of an old group. A regression model is going to just assume that, say, some nice linear regression holds across the entire age distribution. And so that y0 is a linear function of age, let's say, and y1 is a linear function of age. But we have no idea if that is true. The model might be misspecified. There might be nonlinearities. And again, if you have what's called like a lack of overlap, where these groups are quite different from one another, your treatment effect estimates might be driven just as much by the model form of that parametric regression model than by the data itself. So again, it's sort of this propensity scores kind of help identify this space in the data where you can interpolate rather than extrapolate. And again, and then the other drawback goes back to the separation from design from analysis, where if you're just running regressions, you sort of see the treatment effect estimate each time, right? We have a regression of like y is a function of treatment plus covariates. And I might see like, oh, that's weird. My treatment effect estimate, the coefficient on treatment is negative. Like I wouldn't have expected that. Oh, you know, I probably should put in age squared. You know, I probably should tweak my regression. And there's this sort of confirmation bias that happens where you're sort of seeing the treatment effect estimates as you're kind of designing your study in a sense, as you're specifying your regression models. So using propensity scores can help reduce the extrapolation and then also again avoid this sort of seeing the outcome, seeing the treatment effect estimates as you go along. Okay, so after 20 minutes, what is the propensity score? So formally, the propensity score is defined as the probability of receiving the treatment, here denoted A, given the covariates X. I don't have time to get into like the nitty-gritty about the theory underlying them, but just really briefly, the reason propensity scores work is because of two key features. The first is that they are what are called a balancing score. So what that means is that at each value of the propensity score, so like 0.2, the distribution of observed covariates, the ones that, those X's that are used in constructing the propensity score, are the same in the treated and control groups. So the idea is that like, if a group of people all have a propensity of 0.2, that means about 20% of them would be treated, and they all had the same probability of being treated. So which of them actually ended up treated versus control must have just been random. So if we think like within a small range around 0.2, it's just random who's treated and who is control. And so again, it's this idea of sort of a mini randomized experiment. The second key feature, and this is what sort of allows us to match just on the propensity score and not worry about the covariates individually, is that if treatment assignment is independent of potential outcomes given covariates, i.e. there's no unmeasured confounders, then it's also independent of those potential outcomes given just the propensity score. So in other words, we can summarize all of the covariates X using just this single number, the propensity score, without losing this property of unconfoundedness. It doesn't imply that unconfoundedness holds. There may be unobserved confounders, but again, the point is just that for this dimension reduction property, we can reduce all of the X's into just the propensity score. So again, these two things combined basically mean that we can sort of ignore the X's as individual things and use just the propensity score to create well-equated groups. And I see a question which I'll come back to in just a second. I want to say that, and the Rosenbaum and Rubin papers and a whole set of literature since then basically has proven that appropriately using the propensity score can yield unbiased treatment effect estimates. Good ways of doing this, and I'll illustrate one of them today, are things like matching, where you, like for each treated person, you find a similar control. Weighting, where we might use a function of the propensity score as a weight. And then subclassification, so this idea of like forming groups with similar propensity score values. I could spend a week literally talking about all those variations on those. We're going to just see today an illustration of matching. You will see in the literature that sometimes people will just put the propensity score on the right-hand side of a regression model. So they won't do matching or weighting or subclassification. They will just collapse all the X's into the propensity score and put that in on the right-hand side. That is not an optimal way of doing it, basically because it doesn't fix any of those extrapolation issues I talked about earlier. So it doesn't, the better options kind of work to make the samples look similar. Simple regression adjustment for the propensity score doesn't do that. So I discourage that. So a question from Hanak came in, isn't the same regression model used for the propensity score? And so don't we have the same problem of nonlinearity in sort of, we have to estimate a propensity score. So if we have this extrapolation problem, don't we still have it? And basically sort of yes and no. Yes, we do have to estimate a propensity score, and we will use a model for that. The reason it's not as big a deal, though, number one, is there's a lot of evidence showing that misspecifying the propensity score is much less detrimental than misspecifying an outcome model. And so it's sort of, it's okay if it's not quite right. And that's partly because of this balancing property where we can sort of check and see, do we get good covariate balance? Do we actually have similar groups after using matching, weighting, or subclassification? And in some ways, it actually, as long as we get that good balance, we might not care actually if we had the right propensity score model. So there's sort of this tautology there. Second, though, I'm going to only briefly talk about this, but there's a whole literature on what are called doubly robust methods, which basically use both. So they say use a propensity score approach and use an outcome model. And if either of those is accurately specified, then you will get an unbiased effect estimate. So you can sort of hedge your bets in that regard.
And one more question from Nikki.
Yeah, so how do you decide between matching, weighting, or subclassification? And yes, there are crazy numbers. This is why I could talk about it for a week, is it's like, and there's like new things coming out all the time. I always argue that you should pick based on this covariate balance. So we'll see an example as we go along. But the idea again is like, we want to create groups that look similar to one another. And so honestly, I will try multiple approaches and see in this data set which one kind of works best. In my experience, it's actually very hard to predict in advance what's going to work best. So again, the beauty of this kind of design stage is you can try a couple and see what actually works best for covariate balance, and then move forward with that. Okay, let's be really, I want to be very careful about this assumption and be really clear that, again, the sort of Achilles heel of a non-experimental study like I'm describing is that there is this assumption of no unmeasured confounders. I, again, don't have time to get into all the nitty-gritty. Today, I'll briefly show a sensitivity analysis where we sort of pose, well, if one exists, how much does that change our inferences? But there's sort of other things that you can do to help with this, like smart design and extensive covariate measurement. And again, sort of like Robert mentioned, good knowledge of the likely confounders, and then thinking through, how can we measure those, or proxies at least for them in the data that we have. Nicole, I see a question on, is the C statistic what I mean by balancing score? No, I will, I'll come back to that, I think, or maybe bug me again if I don't. But the balancing score, well, I think it will be more clear when we go through the example. So let's make this more concrete and quickly go through this example of this suicide prevention program. So this, again, we had the luxury of this amazing Danish registry data, which basically was a registry of, everyone living in Denmark since, I don't know, 1970. And it was a civil register around sort of family structure, a national registry of patients with different diagnostic information, a psychiatric specific registry, and then a registry of causes of death. And in Denmark, suicides are actually captured quite reliably, unlike some places in the US. I know, at least in Denmark, there's a feeling like suicides are captured in this registry. So the treatment that we're going to be looking at is sort of going to one of these suicide prevention centers. I will note, so these suicide prevention centers were basically rolled out across the country of Denmark starting in 1992. And so there is some variability in sort of who had access to them based on like time and space, basically. That sort of some people might have lived near one and others might not have, or, it came in 5 years after their suicide attempt. There's sort of some naturally occurring variation, and that's useful for our purpose. Separate conversation is that we could use a different design there, like a comparative interrupted time series or something, but let's set that aside. Our comparison group are going to be similar individuals who had also attempted suicide, but did not receive treatment from a suicide center after their suicide attempt. So again, the premise here is, so first, it's really important to kind of restrict to people who had a suicide attempt. And then the idea is that we kind of have to believe that once we condition and match on the variables I'll list, I think on the next slide, there is some randomness essentially in who ended up going to one of these centers and who didn't. And that we can sort of reliably compare outcomes and sort of believe that it's not all just sort of unobserved selection. So we had data from 1992 to 2011, and this was about 6,000 people who went to the centers and about 60,000 who did not. If you're curious about the therapy, essentially the therapy at these clinics were very sort of person specific. They kind of were very much tailored for each person. It included problem solving skills, dialectical behavior therapy, social worker support, etc. People were referred to them from either their medical office or the psychiatric emergency departments, general wards, general practitioners, or also just self-referral. And again, as I just said, there was some variability in access due to the fact that these were rolled out over time. On average, people went to these centers for about 2 months and had about 8 to 10 sessions. So again, the concern though, if we just blindly compare outcomes among people who did and didn't go to these centers, is that the people who go might have been different in many ways from those who don't. They might have been more motivated to sort of identify what led to their attempt and try to sort of prevent a future one. They might have had different socioeconomic situations. So what we'll do is we're going to do propensity score matching to deal as well as possible with the observed characteristics. And then again, a sensitivity analysis to say, well, what if there is some unobserved confounder? So one of the amazing things about this data is that it is so extensive in terms of the covariance. So we have extensive demographics available, education, SES, where they were born, etc. We know about their suicide attempts. And to Robert's point earlier, as is well known in so our outcomes of interest are going to be like repeat suicide attempts. And the field of suicide research knows that, you know, one of the strongest predictors of that are things like the number of previous attempts and the method of the attempt. So it's very important that in this data, we have information on exactly those things. We also have information on their psychiatric diagnoses, and really amazingly, and I don't know if this would be the case in like anywhere else except Scandinavia, we actually know their parents' psychiatric history and whether their parents had any suicidal behavior. And so again, this is like best case scenario in terms of believing that we have captured most of the relevant confounders. So I don't have time in this 45-minute talk to get into the details, but for our purpose today, I will just say that step one is to estimate a propensity score. So in this case, we just used logistic regression. So regress receiving treatment, so going to one of the centers, as a function of these 31 covariates. The propensity score itself is then the predicted probability from that model for each person. So each person will have sort of their predicted probability of going to one of the suicide prevention centers, which is calculated using these 31 covariates. As a sort of aside, I will say that machine learning methods like random forests and sort of more flexible models that allow for interactions and things like that actually work better. In this case, we sort of were a little constrained by the data was in Denmark. I couldn't even access it. It had to be analyzed in SAS. You know, sort of computational challenges led us to use this more simple approach. But in general, I try to use machine learning methods for estimating propensity scores when I can. Okay, so I guess, yeah, like just really briefly, as I alluded to earlier, and actually I already said this, there's 800,000 ways of using propensity scores. In this case, so if you remember, we had 60,000 comparison and 6,000 treated subjects. So that is a scenario where matching often can work quite well because there's this big pool of comparison subjects where basically for each treated person, we found 3 comparison people who looked similar to them, who had a similar propensity score. What's also nice about propensity score matching is you can kind of fine tune it. So in this case, we knew that, and this again goes back to Robert's point, 2 of the covariates that were going to be, we knew sort of from existing literature would be particularly predictive of repeat suicide attempts, was whether the person had any psychiatric disorder and whether they had a previous deliberate self-harm attempt before this sort of index one that we're looking at right now. And so what we were able to do is do what's called also an exact match on those 2 variables. So you can think about it as like for each treated person, we found 3 comparison people who didn't go to one of the centers. They look exactly like the treated person on whether they had a psychiatric disorder and previous deliberate self-harm, and they're similar on their propensity scores. And again, this sort of 3-to-1 match makes sense given the relative size of our groups, and given that we could do this exact match on these strong outcome predictors. The other nice thing about matching is it's quite easy to explain in this huge data set running in SAS. Like it just was sort of computationally easy. It was pretty straightforward. The idea then is, so what we do is we then take those matched samples. So we now have our 6,000 treated and our 18,000 matches, and we will sort of move forward in our analysis after one thing I'll get to in a second, comparing outcomes in those groups, basically acting as if it was a randomized experiment. So whatever, you know, regression or t-test or survival analysis you would do if it was randomized, we will do that in our matched samples. So this table summarizes kind of the success. And so this is the key step. Like this step should never be skipped in a propensity score analysis or any non-experimental study for that matter. So what this shows is, this is just a small subset of the covariates. The unmatched group is before the matching. So we see that before the matching, the people who went to the centers, the PT group, tended to be less male. There were fewer old people. They were less likely to have children, etc. This SMD is this is a common covariate balance metric. So this is the standardized mean difference. It's basically the difference in means for each covariate divided by the standard deviation. The rule of thumb, and so this is kind of a measure of how much extrapolation we're doing. The rule of thumb is that you want these to be less than about 0.1. That if these are bigger than like 0.1 or 0.2, your groups are really quite different from one another and really can't sort of be reliably compared. So you can see here that, sorry, my 7th grader is like, what are you doing? Anyway, I know, I'm all fancy. Okay, sorry. Future McGill, you know, student, maybe, we'll see. So anyway, sorry, you can see that the SMD is before matching. Some of them are pretty big. So 0.55 on any previous psychiatric diagnosis indicates that these groups do look quite different. After matching, so now this final columns, the PT group is the same as it was because we didn't change it. And now this is just the 18,000 matches. And these SMDs, you can see, are now tiny. And, you know, for example, the any psychiatric diagnosis is perfectly matched because we required that using the exact matching. So we now feel more reliable that we can compare the treatment group with their matches. And we've done a good job at creating this similarity. This is this idea of the covariate balance between the groups. We can also do a figure. So this is just a figure version of that table. So now showing for every covariate, and the blue circles, blue hollow circles, are before the matching, and the red solid circles are after. And this is the kind of thing you want to see, where again, sort of after the matching, those are much closer to 0, and all of them, essentially all of them, are below this sort of 10% threshold. So again, this is what gives us confidence that this matching procedure has done a good job at equating our groups on this set of 31 covariates. So let me address a couple questions from the chat. So Nicole asked, is the C statistic what I mean by the balancing score? So no. So a C statistic is basically a measure of the predictiveness of a propensity of a like logistic regression model. We don't care about C statistics, and in fact, actually, if you have a really high C statistic, it's a really bad sign because it means that your covariates basically perfectly predict treatment and control status. And so that's a sign that you really have very poor overlap between your groups. In fact, you kind of want a C statistic that's more like 0.5, like in a trial, because then that's an indication that there's more overlap. So this balancing idea is more what I'm showing here, where you want to see that the covariate distributions look similar between treatment and control groups. And then Kaveri asked, so you could wind up not using some in the sample, those without a match. So yes, and actually, let me, well, I'll just say verbally, yes. So we moved forward with our 6,000 treated and our now just 18,000 comparison. And we don't use data from the, what, 40,000 comparison. So some people, like, that sort of rubs people the wrong way. Like, our intuition is that, oh, we're throwing away data. But one thing I really want to highlight is that in a non-experimental study, our first concern is bias. Our first concern is trying to reduce bias due to these confounders. And we, in this case, are basically saying, we're going to sacrifice some sample size in order to have lower bias. I also am careful to say it doesn't necessarily change your statistical power. This is a little non-intuitive, but our treatment group is staying the same. So for our treatment effect estimates, we still only have the 6,000 treated. So in some ways, our power is going to be driven by that anyway. And number two, there's these old results from Bill Cochran showing that statistical power is highest when your groups are similar on covariates. So like a randomized trial has higher power than a non-experimental study. And so it actually can be that sort of creating this similarity in the groups could potentially actually increase power even if you are losing sample size. So that's just my plug for like, sometimes throwing away data can actually be a good thing. But I know that's sometimes a tough pill to swallow. Let me come back to the missing data question because I just want to make sure to get through the bulk and then we can come back to some of these kind of complications. So as I said, now we say, all right, we have our matches and the balance looks good. So let's compare outcomes. And so we can do like, again, like a survival analysis. And we, in this case, you know, sort of showed that the odds ratios for repeat suicide attempts, death by suicide, death from any cause, indicated quite a protective effect of these suicide prevention centers. You know, we can do a Kaplan-Meier curve and sort of show what that looks like. And again, sort of showing a pretty effective intervention, actually. But of course, the worry, back to this sort of Achilles heel, the worry is that even though we've been able to well adjust for these 31 covariates, there might be some unobserved thing, maybe some unobserved like motivation or just sort of attitude or genetic factor that might relate to their choice to go to a center and their outcomes. So I don't have time to get into the weeds of this, but basically there's a whole suite of sensitivity analyses that exist that sort of basically they kind of, you do like a thought experiment of sort of how strongly related to exposure and outcome would some unobserved variable have to be in order to change our study conclusions. So in this case, we were able to show that basically a binary unobserved confounder would have to have about a twofold association with participation or, you know, attendance at one of these centers and the outcome in order to explain the results for one of the weaker effects. So this is sort of the most sensitive. And what's nice about this is it sort of turns it into a conversation where instead of just someone saying, well, I don't trust your results because you didn't adjust for genetics, we can have a conversation like, is it plausible that a genetic factor would be twofold associated with exposure and outcome once we've already adjusted for all of these other covariates. So again, it just kind of turns a sort of qualitative worry into a more quantitative statement about the robustness of the results. I know I'm like screaming through this, but hopefully it's been helpful. So let me quickly conclude, and then I'll get back to the questions. So again, I think probably many of you are here because many research questions do require non-experimental studies. There are a number of strong non-experimental designs out there. And one thing I do want to say explicitly, I want to be clear that though a drawback whenever you move, so we like experiments because we can get an unbiased treatment effect estimate with no assumptions. Like we just have to have the randomization, and that in a nice, clean, well done experiment, we don't need any assumptions. Whenever you move to a non-experimental study, there's going to be some untestable assumptions. So in this case, we have this, in a propensity score kind of case, we have this assumption of no unobserved confounders. Instrumental variables will have a different assumption, but you do want to think through those assumptions carefully. And sort of related, it's important to measure as many confounders as possible so that you can, that again goes back to Robert's point, we want knowledge about the outcome. We don't use the outcome data, but we want knowledge about it. We also want to have an understanding of the treatment selection process, what led people to maybe go or not go to one of these centers. With large samples especially, we can get really good covariate balance, but again, we should always check that balance when we're doing an analysis. And any non-experimental study like this should also incorporate one of these sort of sensitivity analyses to assess robustness to an unmeasured confounder. So let me, while I'm going to maybe respond to the 2 questions in the chat and then open it up, but I'll leave this slide up for a minute. I'm also happy to share these slides. So Nicole asked, how do you deal with missing data for some of the covariates? Great question, and could be a long answer. Briefly, same way you deal with missing data in general. So multiple imputation is a good strategy. There's sort of mixed results of whether you can do like a missing data indicator kind of approach, like impute, the mean and then include an indicator for whether it was missing. There's sort of mixed results of whether that can work. So not really any good, quick, easy answer there. But again, multiple imputation is usually a pretty workhorse strategy. And then Elias asked, after matching, do you still add your propensity score to your logistic regression analysis for outcomes? Good question. Usually I say no. But again, there is this idea of double robustness. So what is actually better is to include the covariates themselves in the outcome regression model. So basically use the covariates twice. Use them for propensity score estimation, and then like in your matched samples, run a regression where you control for the covariates again there. And in some ways, like, I'm gonna stop sharing now. In some ways I say like, don't put the propensity score in there because like, it's kind of weird. Like, why would our outcome be like a linear function of the propensity score? Sorry, all my texts are coming through now. And so like basically the model, the outcome model is probably more accurate, more reliable if we put the covariates in individually rather than putting in this propensity score, which is kind of a weird function of them, honestly. Sorry, is this helpful if I just kind of roll through the okay, I'm gonna skip one for a second, or no, I'll just go through them in order. Okay, can I comment on the utility of propensity scores for risk factor identification studies as opposed to assessing treatment effects? I have a bit of a pet peeve where sometimes people use the term propensity score when really they just mean logistic regression. Propensity scores really are designed for this purpose of creating similar groups, creating an equivalence or sort of equating groups on a set of covariates. If you're not in a situation where you're trying to compare 2 groups, it's probably not technically a propensity score. So I might be misunderstanding, but people use the term all the time. I just try to be a bit of a stickler for terms and kind of what we call things. And again, I've definitely seen people use the term propensity score, and really it's just a logistic regression predicting an outcome or something. So Nikki asked a really important question that I want to make sure to spend a minute on, because there's some, what's the word, confusion about this out in the world. Can propensity score matching increase imbalance or precipitate bias? How can we be so sure? So again, a little hard to answer this in 2 minutes, but I would say generally no. So there's 2 exceptions to that though. So one is, just like we shouldn't condition on post-treatment variables, you do want to be careful not to include in your propensity score something that could have been affected by the treatment. So there, like you might have heard of colliders. You do not want to condition on a collider. So the safest way to do that 99% of the time is make sure that your covariates are measured before your treatment, and that sort of they are true baseline covariates. There are some like weird scenarios where even that can cause bias, but I actually personally, like, they are theoretically possible. I don't think they are super common in practice. Gary King, who is an old advisor of mine in graduate school, has this paper on showing that matching can lead to an increase in imbalance. Again, I sort of view that as like, yes, it can in sort of weird situations. And this is why we check balance. Like, the whole point is like, we can check and see, did it get worse? And so that's where, like, yes, in some weird scenarios, the matching can actually increase imbalance, but it almost never happens, and you can check for it, you know, to see if it does. Do propensity score analyses differ much from multivariate? Right. So I made a big deal, like, you should check, like, we don't want to have extrapolation. Don't just run a regression. In reality, you might get the same results. Like, if we do a propensity score thing, or if we just control for covariates, you sometimes get the same result. My sort of main point though is I think we still want to be thoughtful about covariate balance, and I'm going to trust a propensity score approach better because I'm going to know that my groups were similar on everything, you know, in advance, and I know that I'm like not going to be relying as much on the outcome. So short answer is, yeah, it might not make a difference, but I'm going to trust it more if I've used a propensity score. So it's kind of weird to just read the questions because then I just talk the whole time.
You're doing a great job.
Like speed questions. Nicole, I'm still not sure what the balancing score is. So that's like a little bit of a, basically a propensity score is a type of balancing score. It's just a balancing score is just a statistical term for something that leads to this covariate balance. The covariates themselves are another balancing score. It's irrelevant for us, but it's just like this idea that the propensity score has these properties that lead to covariate balance. You don't need to worry about it too much. Would I recommend use of inverse weighting as a next step stratification? So I'm not sure I totally get the question, but yeah, so inverse probability of treatment weighting, where you weight subjects by a function of the propensity score, is a very common, especially in epi, common use of propensity scores. It's a totally reasonable approach. I have some quibbles with it because it can be quite sensitive to, like, you have to be careful about extreme weights, and it's more sensitive to the values of the propensity score. But it's usually a perfectly fine approach. Subclassification or stratification, where people might form like 5 strata, usually does not work particularly well. It doesn't lead to very good covariate balance because I think it's not sort of fine enough control. Dr. Kramer asked, have I compared the results of the, right, so back to this point about sometimes the results are similar, basically asking, did we try that in this data set? I honestly don't remember. It might be in the paper. We might have a sentence or two. And again, like it doesn't always change. Like there's not, certainly a lot of examples I've worked on, the results are broadly similar. But you know, as I tell my students, like I at least want to see the covariate balance, and I want to sort of know kind of what these groups look like, so that I have this pet peeve where in randomized trials, we always show a table 1 comparing treatment and control groups, but like I trust that the randomization worked most of the time. And so you showing me table 1 is just proving that, yeah, we randomized and like the randomization didn't get screwed up. In non-experimental studies, people sometimes don't even show that table 1, but that table 1 is crucial to understand how much confounding there is, how much extrapolation there might be, and how similar the groups are. And so in non-experimental studies, I at least want to look at that table 1 and then use propensity scores if there are if there are differences between the groups that I want to try to minimize. Okay, 4:58, and I think there's, yes, I'm happy to share the slides. Susan, we can work out sort of how to do that.
Yes.
And then is it more powerful to include many covariates to match on or limit the number? So basically, in general, the advice, again, there's some like in my 1-minute answer, usually it's better to include more covariates than fewer. And again, it's this, we are trying to satisfy this no unmeasured confounders. So if you don't include something, you're kind of turning it into an unobserved confounder. So it's usually better to include them. If you have a small sample size, if balance is not good, you might need to be kind of picky. And that's where, back to Robert's point, focusing on including strong outcome predictors and sort of those that are kind of probably really going to lead to outcome differences is really important. And those should be the ones prioritized. So, okay. Everything you need to know about propensity scores in 59 minutes.
Well, I really want to thank you for this gentle introduction to propensity scores. I think that, you know, I learned a lot again. But you really reinforce why it's so important for us all to make really good friends with our local biostatisticians and to be talking to them from day 1 of the idea of the work that we want to do. You had a very elegant way of walking us through all of the complex decision points that we need to be thinking about. And I also, you know, just want to acknowledge how darned efficient you are with being able to monitor the chat simultaneously and respond to questions.
It's a skill I've developed.
Well, all these new skills that are coming out in 2020. So thank you so much for spending some time with us on our seminar series today. There's lots of accolades, so I hope you'll have a chance to just see all the appreciation from our group for sharing your knowledge with us.